Hello everyone, it's Dr. Mohib, and in this lecture we will be giving you an overview of step style questions. First of all, step 1. Step 1 basically deals with your basic sciences. It includes topics like embryology, anatomy, physiology, pathology, pharmacology, biochem, immunology, histology, etc. The main theme of Step 1 style questions is to link your basic sciences with clinical decision or real life scenarios. So, the common style questions asked on your Step 1 exam are to make diagnosis based on pathophysiology clues, mechanism of drug or an enzyme, histology or immunology correlations, side effects, and lab patterns. On the other hand, in Step 2 mainly focuses on your clinical knowledge. In step 2, you are tested on real life scenarios or questions where you will be tested on your clinical decision making capabilities. The common style questions asked on your step 2 exam will be to make diagnosis, next best step in management, best test to order, and prognosis or complications of a disease. Then we have step style questions layout. Whether you are going through your step 1 or step 2, the layout remains same. It's not a universal rule or universal layout, but it's a general rule or general layout where questions presents or question stems presents in a following manner. At first we have an intro or presenting condition followed by patient history, then we have vitals of the patient, physical examination, lab values, diagnostic tests being performed, then we have question asked, and at last we have answer options of the question stem. So let's have an overview of a question based on the following layout. In this question stem, a 24-year-old man comes to emergency department with severe chest pain. The pain started suddenly while at rest and radiates to his left arm. This was the intro or the presenting condition. Then we have medical history or the history of the patient. He has no prior medical history but smokes one pack of cigarettes daily. His father died of a myocardial infarction at the age of 45. This was history. Then we have vitals. On his arrival, his temperature is 37 degrees centigrade, heart rate 110 per minute, BP 150 by 92, and respiratory rate 22 beats per minute, and oxygen saturation 92% on room air. This was vitals. Then we have physical examination. He appears diaphoretic and anxious. Jugular venous pressure is normal. Cardiac exam reveals an S4 gallop. Lungs are clear to auscultation and no peripheral edema is noted. This was all about physical examination. Then we have lab values. Lab test shows elevated troponin I and CKMB levels with an LDL cholesterol of 170 mg per deciliter. These were lab values, and then at last we have our diagnostic test ECG being performed. ECG demonstrates ST segment elevation in lead 2, 3 and AVF. Then we have question asked, which of the following best describes the underlying mechanism of this patient's condition? This is the question, and these are the answer options. Whether it's a coronary artery vasospasm leading to transient ischemia, fixed atherosclerotic plaque causing stable angina, rupture of an atherosclerotic plaque with superimposed thrombosis, increased myocardial oxygen demand due to left ventricular hypertrophy, or coronary artery embolism from atrial fibrillation. So this was all about a typical model question. So there isn't any universal rule that a question stem would look like this, but majority of the question stems look like this. There would be some parts missing in different questions. Then I have my own approach to step style questions to solve step style questions, whether you are going through step 1 or step 2. The first thing to approach a step style question is to read the last line. The last line will give you an idea what is asked in the question. Then go through the answer options or have a quick glance at the answer options so that you can, when you will be going through question stem, you should look for the following clues related to the answer options. Then go through the question stem, then look for high yield clues and buzzwords, then match it with answers, and at last eliminate distractors. Now let's solve some questions based on this approach. There are different type of step 1 style questions. At first we have a typical single type question. So let's go through question number 1. Now, first thing is to do is to read the last line. Which of the following is the most likely histopathologic finding in this patient's lungs? Now, what we have to do, we have to find histopathologic findings. Now, have a quick glance of the answer options. Hypertrophy of bronchial mucus glands, infiltration of eosinophils and mast cells in bronchial mucosa, destruction of alveolar walls with loss of elastic fibers, fibrosis and honeycombing of interstitial lung disease, intra-alveolar accumulation of hemosiderin-laden macrophages. Now, let's read the question stem. A 60-year-old man comes to the clinic with progressive shortness of breath over the past 6 months. Now, the differentials for progressive shortness of breath include cardiovascular problems, respiratory problems, or hematological problems. He reports a chronic cough productive of scant sputum. His medical history is significant for a 40-year pack-year smoking history. He worked in construction for 25 years. On physical examination, he appears thin with pursed lip breathing. Chest auscultation reveals decreased breath sounds bilaterally and prolonged expiration. Percussion of the chest is hyperresonant. His oxygen saturation on room air is decreased 90%. The buzzwords or the key things to look in this question is his smoking history. Then he appears thin with pursed lip breathing. This is another buzzword. Then this patient has prolonged expiration and decreased breath sounds bilaterally. On percussion of chest, we have hyperresonant sounds and decreased oxygen saturation. The PFT shows FE1 is markedly decreased, FVC is moderately decreased, FE1 by FVC ratio is decreased again, total lung capacity is increased, and diffusing capacity for carbon monoxide is also decreased. The following PFT shows this patient has an obstructive type of lung disease. We have chronic bronchitis, emphysema, asthma, and bronchiectasis. These are few of the diseases. These are the obstructive pattern lung diseases. But the in decreased DLCO only occurs in emphysema. So the correct answer is emphysema. So what histopathologic finding occurs in emphysema? In emphysema, we have destruction of alveolar walls with loss of elastic fibers. So the correct answer is destruction of alveolar walls with loss of elastic fibers. So the correct answer is this. Then option number A, hypertrophy of bronchial mucus glands. This occurs in chronic bronchitis. Infiltration of eosinophils and mast cells in bronchial mucosa occurs in asthma. Fibrosis and honeycombing of interstitial lung disease occurs in interstitial lung disease, which is a restrictive pattern of lung disease. And intra-alveolar accumulation of hemosiderin-laden macrophages occurs in left heart failure. So it was all about step style questions. Then we have another type of step style questions where two questions are asked at the same time. Now again, jump to the last line. What is the most likely diagnosis and what is the next best step in management? So there are two questions asked at the same time. The answer choices are give IV heparin, immediate IV beta blocker, immediate IV nitroprusside, coronary catheterization, IV fluids, and permissive hypertension. Now let's go through the question stem. A 58-year-old man with a history of long-standing hypertension, type 2 diabetes, and chronic kidney disease is brought to the ER with sudden onset severe chest pain radiating to the back. Now the differentials for sudden onset severe chest pain are CVS, respiratory, and GI problems. In CVS, we have acute coronary syndrome, then we have aortic dissection, or we can have a pericarditis with tamponade. For respiratory, we can have pulmonary embolism, and for GI, we can have Boer-Haave syndrome. Now, this patient, he also appears diaphoretic and restless. His vitals are BP consists of 210 by 110 mm of Hg, heart rate is 110, respiratory rate is 22, O2 saturation is 97%, which is normal. A new diastolic decrescendo murmur is heard along the left sternal border. This is a buzzword. On chest X-ray, there is a widened mediastinum. This is again a buzzword. Labs shows CRET is 2.8 milligram per deciliter, where baseline is 2.2, and a potassium of 5.8, again elevated, and troponin levels are normal. So ECG shows sinus tachycardia but no ST changes. So what do we have? If this patient had ACS, then his ECG would show some changes. So it is not an ACS. For aortic dissection, this patient have a widened mediastina, which again correlates with aortic dissection. A new diastolic decrescendo murmur along the left sternal border again correlates with aortic dissection. This new murmur, a diastolic decrescendo murmur along the left sternal border, is actually an aortic regurgitation. When aortic dissection extends into the root of heart or aorta, it causes a new murmur to appear. This again correlates with aortic dissection. A pericarditis with tamponade would have typical symptoms which are not present in this patient. A pulmonary embolism would have dyspnea and hypoxia since this patient has a normal oxygen saturation. This again is incorrect. And for Boerhaave syndrome, this patient would have a history of violent retching or vomiting, which is again not present in this patient. So we have a diagnosis of aortic dissection. Then the second question being asked is, what is the next best step in management? Now, the concerning thing in aortic dissection is increased shear stress. Now, the management of aortic dissection mainly correlates with decreasing the shear stress on aortic wall. It can be achieved by both decreasing the heart rate as well as decreasing the blood pressure. So we have to pick an option which decreases both heart rate as well as decreasing the blood pressure. So the correct option is give immediate IV beta blocker like labetalol or esmolol. It would decrease both heart rate as well as blood pressure. If we give an so the correct option is immediate IV beta blocker. If we give this patient IV nitroprusside, it would decrease blood pressure, but by reflex mechanism, it would increase the heart rate and worsen the condition. The IV heparin is not indicated in aortic dissection, but rather contraindicated as it would further deteriorate the patient condition. Coronary catheterization is indicated in ACS, which this patient doesn't have, and IV fluids and permissive hypertension is indicated in stroke, which this patient also doesn't have, so we can exclude this option as well. So the correct option is immediate IV blocker, IV beta blockers like labetalol or esmolol. And then we have third type of questions in which the diagnosis, or you can simply solve this question just by going through the last line, which would indicate or show that this is a correct way to solve the question. Which part of the GI tract is primarily responsible for absorption of vitamin B12? So it is a simple physiologic question. Which part of the GI tract is primarily responsible for absorption of vitamin B12? Answer choices are duodenum, jejunum, ileum, stomach, and colon. So if you know which part of the GI tract absorbs vitamin B12, you can simply answer it. So the correct option is ileum. Ileum absorbs vitamin B12 as well as bile salts, while jejunum absorbs vitamin B9. Duodenum absorbs mostly the iron, magnesium, calcium, etc. different minerals, while colon absorbs water and fluids. So if you know the answer, or if you go through the last question, you can simply answer it without going through the question stem. Now let's read the question stem. A 24-year-old medical student presents to the clinic with complaints of recurrent abdominal pain and bloating. She reports alternating diarrhea and constipation that have been ongoing for several months. She has tried dietary changes without much relief. There is no history of weight loss, blood in stool, or recent travel. On exam, her abdomen is soft with mild diffuse tenderness, no guarding, and no organomegaly. Basic labs CBC, CMP, ESR, and CRP are all within normal limits. Stool studies are negative for ova and parasites. The physician reassures her, explains that the condition is chronic but not life-threatening, and emphasizes stress management and dietary modification as part of the treatment. This patient has IBS, irritable bowel syndrome. So this was all about step style questions. Thank you.